innovations and hopefully bring them to a global audience. Many of the topics come from our community, with scholars and faculty expressing an interest in many of the discussions that we're about to have. HLA programs are built on 6 pillars. The leader is an innovator and entrepreneur, the leader is a communicator, the leader is a manager, the leader as a negotiator, the leader as a follower, and the leader as a philosopher. If you are interested in becoming a HLA scholar, why not get in contact? Many of the episodes in HLA Live will cover one or more of these important pillars. The HLA team consists of Pedra, Eamon, Tim, Riddy, Alistair, Adil and Trisha, and a range of other HLA scholars and faculty. Episode 27 of HLA Live is on homelessness and health, hosted by our scholar Patricia Vincenzo.
Hello everyone and welcome to this evening's HLA Live episode. I'm joined today by a fantastic panel discussing homelessness and health. Our panel this evening, joining us, is Dr. Caroline Schulman, Jane Cook, Dr. Philip Timms, and Dr. Kleena Nikali. Our first question to the panel this evening is actually a question I posed in a previous discussion on prison healthcare, but I wanted to see if there was any contrasting or similar views within this topic. So the first question is, what changes, if any, have occurred to the provision of healthcare for individuals with no home over the past 10 years?
I think we now have some ways that have some evidence of helping people better with mental health problems who happen to be homeless or socially marginalised. There's Housing First is obviously it's not a mental health service, but it's a very effective way for many people to address their multiple needs. And although the evidence is up and down and depends where you get it, it's, in my view, that's a real step forward that should be more aggressively pioneered. In London, I think it's only being done in Islington at the moment. The problem with it is getting buy-in from all the services that you need to really make it work. But it's a great way to say, actually, if you're not well and you're homeless, you deserve a place of your own. You don't have to go through this awful farrago of going through, sharing a room in a hostel and having your own room in a hostel, and all that nonsense. And it reflects a bit the project we had with Thamesreach in the mid-90s, where we had a number of beds in South London where we could get people straight off the street, people usually with schizophrenia, straight off the street into a small flat or bedsit of their own. It worked really, really well. So I've got a lot of time for that. There's a thing called critical time intervention, developed by Ezra Susser in New York. That basically just means that you titrate your input to a person, just as you would titrate a medication. So in times when it's more likely to be stressful, you start saying them 2, 3, or 4 times a week rather than once every 2 weeks. It sounds blindingly simple, but if you don't think of it in a structured way, it doesn't happen. And I think that's a real step forward. People like Peter Cockesall and John Connolly in London have pioneered the notion of introducing an awareness of the effect that multiple traumas have on people. And many people who are homeless have been through multiple traumas, and this often affects the way that they interact with services. And they're written off as difficult people. They're just people who've had difficult lives. And if we understand that and understand the effect of these traumas, we can find more effective ways of working with individuals. And John Connolly has pioneered a kind of pre-therapy unit where a lot of people aren't particularly interested in or familiar with the benefits of psychotherapy, and he has a unit in Westminster where you can people can just drop in, chat, and ease their way in easily to high quality psychological therapists. So certainly in mental health, I think there have been some real improvements in the last 10 years.
I suppose I could come in. I mean, I think in terms of physical health and addiction, I think there's a growing recognition over the last 10 years of the complexity of ill health, I think, of this population. Certainly, I think there's more awareness generally that we're dealing with people who often have this real combination of mental health difficulties, substance misuse, and physical health issues, which I think, there's growing evidence of the severity of that. So I think people are sitting up a little bit more and recognizing this huge inequality and inequity actually within our services. And I think alongside that, there's more appetite for developing more integrated services. So I think, for example, things like pathway teams, and Cleena can talk about what she's doing in Dublin, but certainly, and I've been involved with multidisciplinary teams within hospital settings in London, whereby when somebody's admitted to hospital or even attends hospital, they're seen by a multidisciplinary team to try and support them in a holistic way, to try and ensure that all of their needs, as much as possible, are addressed while they're in hospital, and also that they're supported into appropriate accommodation and support services in the community. So I think there are growing numbers of pathway teams now, or other homelessness teams within hospitals. So I think that's been a real move forward. And I think the other thing is there's been more outreach as well. So I think people are recognizing that if you're going to support this population, you need to actually take care to where they are. So obviously
Somebody had to do it.
Phil's team, they set up a fantastic outreach service for people with mental health problems within the community. And I think there are other outreach nursing teams that work with people on the street now with other outreach services, certainly growing numbers in London. And also in-reach into hostels, so increasing health inclusion teams working to support people within hostels. So I think that's been a really positive thing. And also we have things like Find and Treat team, a team that goes out, finds people, checks them for TB, checks them for bloodborne viruses, and actually the team have been instrumental in supporting people since COVID as well. So I think so I think there've been some really very major moves forward. And I think the only other thing also in relation to that has been a growing recognition that actually getting peers involved and getting peer support is also has grown in recognition that actually when you're working with people with this complexity, trying to get people to support them who have lived experience can be incredibly powerful. So I think there have been some really good movements in the last 10 years, but also recognition that complexity is increasing, numbers of people have been increasing, and so the health has not kept up.
And I think you mentioned pathway several times. I think we now have, courtesy of Nigel Hewitt and his colleagues, the faculty for exclusion health, which means that we're no longer just scattered, eccentric fanatics doing this sort of work. It's become reified within medicine to a certain extent, not enough, I don't think. But I do remember before Pathway, it really did feel as though, we were pretty marginalized. We were indulged perhaps by our employers, but there wasn't a sense very much that this was a thing in itself that was actually important that everybody should be doing. And I think we're beginning maybe to get to that, somewhere near that point.
Yeah, I would agree with Phil and Caroline. I think the last 10 years have seen a realization of the profound effects on people's, health, particularly through the vehicles of mental health, of severe early life adversity, and how people's social conditions affect their health. And it's hard for me because my own journey in inclusion health has very much been over the last 10 years. So it's hard to know what, how much is my own perception changing and how much is actually the world I work in changing. But I see a recognition of the, homelessness and addiction and severe mental illness not being separate, unrelated things, but being a very defined pathway that some people are set upon early in life. And of the fact that drives a lot of the kind of activity that as doctors and nurses and, anybody who works in health that we need to do. And I've also seen, we've done a huge amount of work in Ireland over the last 10 years, initially led by Austin O'Carroll, who's a GP, who set up a training scheme, a GP training scheme specifically targeted at getting practitioners ready to work in areas of deprivation. But we've really seen an explosion in interest and hopefully a change in how people practice. One of my best compliments or best reviews was overheard. I can't remember who it was. One of my colleagues overheard it on a outreach bus, but one homeless person was saying to another, you know, they must have done some training down there in James's. They've got much better at dealing with homeless people. And I was like, yes. But yeah, I mean, for me, it's on a philosophical level. I think it's trying to move from a very kind of moralistic Dickensian, you know, we will punish people individually and as a society for being poor and being born into disadvantage, to hopefully a recognition that actually it's up to us as a society, as healthcare providers, to change how we do things to meet the needs of those with the greatest needs, because otherwise we just don't meet them. You know, standard one size does not fit all. And it's cool. I have to say, I think younger people get it more. And I don't know, again, that's maybe just me being optimistic, but I do a lot of work with medical students now, and they're really passionate and interested in that approach. I think it's maybe a more human-centered approach than the way that, you know, you guys traditionally get taught a lot about a disease or a group of diseases or organs at the time, but actually what we work with as doctors is a person. And I think they have an appetite for a more reflective way of thinking about, well, how am I going to treat this person in front of me? I have to say, unfortunately, Phil, I don't think we were trying to get funding for an inclusion mental health service to kind of take the same trauma-informed approaches. I'm a massive fan of John Connolly. I think you know, everybody should listen to him talk for an hour. But that's been a bit slower. But we've now got 2 inclusion health specialty teams in the hospital. So they're hospital doctors, you know, specialists, hospital specialists. Now our specialty is inclusion health. And I think that that's really important to see it as a thing that healthcare providers do. You know, it's like geriatrics or palliative care or psychiatry. You know, it's a need that you need training in to meet to some degree, to lead it.
Well, one thing that hasn't happened to the degree that I would like it to have done, certainly in King's, where I work, is that exclusion health isn't quite yet an integral part of the curriculum. Again, interested medical students find their way to us, but it's we still that was one of the jobs I gave my successor when I left the start team, but so I'm going to blame her. But not myself, not having done it for 20 years, but
we teach medical, all this stuff that actually you don't need, or, you know, by the time you get to need it, like the pathways of the nerves in the, I don't know, upper arm, like, or the lower arm. If you're going to do plastics, you're going to, you know, it's going to be so far from that anatomy class. You're going to need to relearn a lot of that detail. And yet we just don't teach them about how to act on social determinants of health, even though that drives so much of what we do. And it's just so out of balance. I think we're not doing them a service in denying them that education.
And I think in the last 10 years, we've seen this massive increase of rough sleeping. So it's, you know, increased by 165%. And it's really, I think, been very, very visible. So, and also in respect of that, then, there has been a greater recognition of, you know, that this is a really big issue. And I think, you know, that, and now we've got the funding through the Rough Sleepers Initiative in England, and that's a real recognition of the issue and that something had to be done. And I think it has been very much about reframing homelessness, so seeing it within that public health context, but also within a safeguarding context. And also now we're starting to see people challenging those thresholds where before, you know, and I know Caroline, when we worked together, it was, you know, it's been a real struggle to try and get social services to respond in an appropriate manner. But now it is being reframed within a safeguarding framework, and recognizing that within the, you know, people experiencing homelessness, there is a great vulnerability and frailty, and we have to think differently. And also that a recognition, there's a lot more evidence, like around the the early mortality within this client group. So now data is being collected about death. So you can actually evidence that, you know, the average age of death of a man who's experiencing homelessness is 45. And for a woman, I think it's gone down even further, 42 in the latest ONS data. And so, and it's also been, you know, some of the work that Caroline's been involved in around end-of-life care is that recognition that it needs to be that multidisciplinary response, as Phil was referring to. And with the funding that's coming out through the Ministry of Housing, Community and Local Government, and we're seeing the development of those multidisciplinary teams, so recognition as well. But in some areas, they're now employing social workers, which is really what's needed. Who can have that language to talk about what the need is of an individual from a social care perspective. And even, you know, with the Housing Act, it was really difficult to get people who were homeless picked up by housing because they were just, you know, deemed not to be a priority. And now with the Homeless Reduction Act and duty to refer, that is making a change for individuals to actually be properly housed. So I think there's some real system change that has happened in the last 10 years, and particularly in the last few years.
Sorry, shall we tell our audience what the Homelessness Reduction Act is?
Yeah, no. So
yeah,
so the Homeless Reduction Act came in, I think, 2017. And it was because of the Housing Act, you had to fit in with you had to be deemed to be in priority need, which was you either had to be pregnant or fleeing domestic violence, or of a, you know, elderly, so particular age, or if you'd had an emergency like a fire or flood or something. And if you had health problems, they had to be really extreme, and you had to prove it, and they had to be enduring, and that was interpreted in different ways. So then the Homeless Reduction Act came into being to recognise that there are people who are homeless, that their needs need to be met through a housing route as well. And there is a duty on several institutions to refer people into their local housing team. So that's the Accident Emergency Department, hospital wards. So it's looking at hospital discharge, having a better referral pathway into housing. And, you know, there's been had to do a lot of work about educating health staff about how to make the referrals, and housing, you know, how to develop that partnership has been key. But it's also prison, urgent care centres. So if they come across someone who is homeless, then they have a duty to actually make a referral. And so in some areas have been great about hospitals developing resources that will support that referral into housing. And then with housing, they're supposed to develop a personal plan for that person, which includes health issues. But in some of the pathway teams, of course, they have housing workers within the hospital who do that kind of work, and you know, they're key to getting people into housing. We still see people discharged to the street, and that has, you know, that needs to change really.
I'm glad you mentioned the housing worker as part of the team, because our team started in the early 90s with a housing worker, and then we lost it. And these things seem to churn depending on what local funders are happy to fund. So we lost our housing worker. We gained a psychologist in the end. So it would still be great to have a housing worker though. And again, I think what you brought out is the fact how much what we do depends on the environment that we're working in. I have to say, I feel rather guilty, because when I started my consultant role, I thought 20, 25 years we'll have this licked. You know, we won't need a specialist team like ours in London. It'll be done. And of course it's worse. But that's not, it's not worse because of us. It's because again, there's this tension between looking at the technical things that we do in our work, but also what's creating these conditions. And these conditions are created by political decisions. And we haven't done a good enough job, I think, in making it blindingly clear that homelessness is not a natural disaster. It's not a mystery. It's not a tragedy. it's a willed phenomenon created by our politicians. Now, what we do about that is another question, but I think in terms of teaching medical students, we need to be very clear about that.
Absolutely. I agree, Phil. And I think certainly for me, something that no medical student or nursing student should leave college without is that concept of structural violence, which I presume you're all familiar with. Actually, for the listeners, I might explain it. So it's preventable suffering that is caused by decisions we make at a societal level. So, you know, housing policy resulting in people being homeless, how we fund our education system, how we fund prisons, how we look after disability, all of those things create preventable suffering that, you know, ultimately as a society who elects a democratic society, we are responsible for making those decisions. And I agree, I think it's very important to, you know, we live in an era in which it's all about individual responsibility and individual choice. That's the, you know, political philosophy of the day. And I think, you know, as frontline practitioners, we see very clearly that that's not the case. And I think we need to be strong in calling that out. Yeah, I had another point and now I've forgotten it. But yeah, I agree. And I think that's the dispiriting thing to see. I certainly haven't seen any political change here in Ireland. And I think the other thing that we can advocate for that we see is the huge cost, financial, economic cost, as well as the suffering cost, the individual cost of those policies. You know, in Ireland, state care for a child, foster care for a child can cost up to €250,000 a year. Prison is 80 to 200,000 a year. Very expensive acute hospital inpatient stays. I'm sure you know, I know you see the same thing in the UK. So that, you know, something we're sold this lie that it's too expensive, it's too costly to solve these social problems that are giving rise to what we're seeing, but the reverse is true. And I think we have a duty to point that out. And I think part of that is also health economics. You know, our ways of measuring the economic impact of health related interventions are very limited, and we don't look at long-term impact. We don't look at impact beyond the individual, you know, what's the impact on their family and community. And I think one of the things that we could hope for in the next 10 years is a method of health economics which does that in a more meaningful way. Because I think that's where we can really show to our funders, yeah, pull the housing worker from my team and you will end up costing 100 times more for X, Y, and Z reason.
Yeah.
And also what's been talked about a lot more is adverse childhood experiences and the impact that we're now seeing years later of people who are you know, become homeless and then are also, you know, traumatized and re-traumatized through being homeless and the systems that they've often had to try and engage with. And when we had siloed systems, that doesn't work at all. It is about having that integrated way of working and, you know, having that very person-centered approach rather than thinking about having to, you know, people who are siloed and you are expected to fit into the system rather than the system respond to your particular needs. And I think also what we've seen in the last couple of years as well is a lot more psychology within the system. So there's John Connolly, but I was also thinking of the work of Nick Maguire in Southampton and Steve Weatherhead up in Manchester, I think Steve's in. But it's we're seeing a lot more psychologists come in and work thinking of the psychology and hostels team who are having, you know, great results, you know, seeing giving people time and engaging with them in a quite an appropriate way, you know, going into hostels but slowly engaging with people, and like John does, you know, that very softly approach rather than imposing on people. And I think as well the models that have developed, so the in-reach into hostels and outreach, so we're seeing, you know, nurses in a lot more areas across England and specialist GP practices now providing that in-reach and outreach, which is absolutely key.
Yeah, I mean, I think it is really vital. I think I would like to just say, I mean, referring back to the duty to refer in housing, is there is this duty because it's been recognised that homelessness is very much a health issue in that however, it's a completely preventable health issue. And as everyone has said, you know, we have often people have been let down from childhood throughout their lives, even from pre-birth onwards, and let down by society. So we really do have a duty to support, but you don't always necessarily get what you want from local housing authorities, local authorities, when you do a duty to refer. So I think it's terribly important that we as healthcare providers and professionals continue to strive and advocate for everybody that we see, and advocate as much as we can. And I think and I think really also relating to what you were saying, Jane, in terms of the inreach into hostels and the psychology in hostels. The other thing that we've been working on recently, as Jane said, was around palliative care and homelessness, something that is all too needed because of the incredible toll that homelessness and the complexities are having on people's lives. And I think the whole approach there is very much, it's a whole reframing of how we support people with just multiple and complex needs, to seeing who they are, where they are, what their wishes are, and to explore with them what living well means. And I think it's not just about planning for a better death, it's around actually supporting people to actually explore where they are and their insights, and explore what living well is, rather than we've always been thinking we've just got to get people off alcohol, we've got to have a recovery model, but actually that doesn't work for everybody. People have been traumatized quite dramatically throughout their lives. They need a very different approach, and it has to be that person-centered, holistic approach at really exploring what's important to them and working with their priorities.
It's a time in which people, you know, it's a bit like children. So I think a lot of the blame and I don't know what the right word is. Yeah, blame and maybe less caring ways of dealing with homeless people that we have, or people who are socially excluded, when they're dying, it's you're really confronted by their humanity. I think that it's really powerful, that work that you've been doing, because yeah, it does. It brings that, okay, right, this is this person. What can we offer them? Rather than what do they need to do? And it's a lovely model to have. And palliative care physicians and the whole palliative care philosophy fits in really nicely with a much more, okay, you are where you are, and what can we do about it?
It brings to mind one of the first patients we had with our outreach team, who moved into one of the 10th Street projects in Bermondsey, who was there for about 2 years before he died, and it was one of the most rewarding pieces of work I think I've been involved in, because it was clear his quality of life was massively improved from living there and having some input from us. And to slide sideways slightly, the discussion we've been having sounds to me as being appropriately to do with re-psychologizing medicine.
Absolutely.
The book I haven't written, well, I haven't written any books, few chapters, but the book I'm planning to write in my mind, which may never happen because I'm too lazy, is talking about medicine as a relationship-based activity.
Absolutely. Phil, I'm in a room to make you write that, because we need it. Okay,
great. I don't profess to be any great expert, but we've got lots of experts around, and that's probably the one thing I learned from my job, was that it's all about creating and maintaining helping relationships. Once you've done that,
unless you're a pathologist, you know, that's what medicine is, and nursing, physio and everything. I don't know when we lost that bit of it, but it's such a lot to us all, because like we lose practitioners as much as patients lose. Yeah, I mean, I always find I get told a lot, like, oh, you're an angel, you're a saint, you work with all these difficult. Actually, I'm having the best time at work.
Exactly.
Having great love my patients. We like just brilliant. I love my colleagues. And it's because we focus on the relationship first, I think.
And I think that is particularly rewarding and exciting, because it's more real. You're not dealing with somebody in an artificial environment, they pluck them away. You really don't know what's going on in their life. And the minute I started doing this work, I thought, actually, this feels real. Whereas ward-based psychiatry, where somebody comes into the ward, a junior doctor who doesn't know very much about anything, gives a partial history to a consultant who's probably on their way to doing private practice somewhere, and it's just a crazy way of doing things. And I think the notion of outreach, the notion of getting alongside people and of focusing on the relationship is actually the future of medicine. And I think in terms of talking about social and economic determinants of ill health, we can sometimes sound as though we're doing ourselves out of a job a bit. You know, we're saying this isn't real. But on the positive side, I think exclusion medicine and mental health work has a huge amount to teach the rest of medicine.
I was going to say, Phil, as well, about 30 years ago, there was a team that came out from NHS England to work with the different teams that were working with people who are homeless in London. So when I was with the help team in the East End of London, and this team came out, and at the end of the report, they said, if you get healthcare right for homeless people, you will get it right for the rest of the population. And that's so true. And I think a lot of the work we do within health inclusion is very principle based. So we are thinking about issues of compassion and empathy, and thinking about, you know, the kind of the qualities that you want to see in a service. How accessible is that service? How flexible is that service? You know, how appropriate, how equitable? And it is about framing it within social justice. And as healthcare workers, we do have that duty and responsibility to be speaking out. So, and it does make a difference. And I think it's also thinking about commissioning now where we are, and we've got this integrated care networks, and that must include people who are excluded. So thinking about population-based, when they want to know about tackling health inequalities, it's also making sure that all those groups that are excluded, including those in areas of deprivation, are included in that data collection and the commissioning of services, and bringing together health, housing, and care. So, yeah.
And that's why I term inclusion health, because it's not specific to homelessness. You know, homelessness is a symptom of social exclusion, and a very profound loss and a terrible trauma, but it's not, you know, you can be a housed Irish traveller and have similar needs to somebody who's homeless. And just, I have kids, and I'm total Irish mammy, so like, it's like being a good host. If you're inviting somebody to your house, you should be thinking about what kind of stuff do they like to eat, what games do they like to play, what might be difficult for them. It's just about, you know, trying to be human, trying to think about other, and realize that some people are going to need a lot of extra help in order to get the same outcomes. I mean, I think that law of inverse care provision, or, you know, Tudor Hart's law, have you been taught that?
Yes.
Yeah.
I've tried to teach other people that as well. I don't know how it's worked.
But, like, you know, the people who need whatever you're doing, whether it's psychiatry, palliative care, or wound care, or whatever it is, vaccinations, the people who need it the most are going to be the ones that take the most effort and thought to deliver. So, you know, we're thinking about COVID vaccines. Who needs it the most? Travelers, Roma, homeless people, you know, undocumented migrants. So you need to automatically, as soon as you're thinking about a health intervention, be thinking about, okay, who needs it the most, and what are all the extra steps that we're going to need to do, because our lives are so different. You know, there's not something fundamentally more challenging in vaccinating travellers. The problem is that the people who on the National Irish Vaccination Committee, there aren't travellers on it, so there's nobody who understands their lives. So it's really simple.
And also ask people who are experiencing homelessness what they need. They can tell you directly, this is what works, this isn't what going to work. It's around co-design and co-production of services and resources, and then you'll get it right.
Which is also coming back to that, you know, you're having somebody over to your house, you're not going to just, like, you know, shove food into them without asking them what would they like to eat. It's been a decent relationship, human being person.
I think one part of this is getting away from, I think, you see, medicine has run away from social determinants and the notion of the relationship, because it's wanted to be scientific, viewed as scientific, and it's understandable. And until 100 years ago, we were all quacks. So we've only known what we're doing for a very small amount of time. But I think that it's time for the pendulum to swing back, if it was ever swung the right way. I don't know. And there's an increasing amount of evidence that continuity of care actually results in better healthcare. So how we're going to achieve that, I don't know, but every homeless team I've ever come across has tried to ensure continuity of care. I think it's it's so simple, but very, very powerful.
I'm going to have to interrupt you. It's a great conversation, but we've got about 10 minutes left. So I'm going to move us on onto another question, which I'm sure our audience all want to hear your thoughts on, is what advice can you offer to colleagues working within primary and secondary healthcare when delivering healthcare to homeless patients?
Go around one item at a time. I'll start. Don't make assumptions about drug and alcohol use, adherence to treatment, willingness to collaborate with treatment, all that. Just don't make assumptions. Homeless people can be you can get just as good outcomes as anybody else. They want to get better just as anybody else. There may be problems, but that's not the issue. So just don't make assumptions.
I come in and say, don't try and solve all the problems in one go. People are coming with multiple complexities. Start from their priorities where you can and urgent issues, find out what's important to them. And also recognize that no one person has all the answers for anybody, and there needs to be a really multidisciplinary approach. So liaise with other agencies. So liaise with your addiction services, your mental health services, with your primary care, your secondary care, housing workers, and I think really utilize people who already know that person, and you can gain huge amounts, whether you're working in primary care or in secondary care or somewhere altogether different, that there will be, if there are people that know the person that you're working with, use them, work with them, work alongside the person you're working with, and also the people who are supporting them, and go, but take your time and recognize that the most important thing is developing that relationship and building up trust.
And for me, it's getting to know your partners. So yeah, as Caroline said, know that you are part of a team, so you're not on your own, but also get to know the voluntary sector agencies as well as the statutory agencies. And I would say as well to take the opportunity to actually go and shadow or go out with the outreach teams, and join organizations such as Medics or Doctors of the World, and you know, and also join the faculty and pathway or the Queen's Nursing Institute homeless health program. You'll find people there who will support and mentor you, but also give you that opportunity to go out and shadow people who are already in the field, so you get some experience as well.
My piece of advice would be what my amazing nursing colleague Anne-Marie, who I just absolutely love her, she's so wise, but she says always look beyond the behavior to the person. And I think that we don't, certainly doctors don't get taught that. I don't know if it's taught more to nurses, but, and it's really helpful. You know, don't take whatever it is personally. Don't get attached to kind of overemphasizing somebody's behavior. Look beyond, you know, what's that behavior telling you? Are they frightened? Are they hungry? Are they in withdrawal from methadone? What is that behavior coming from? And to come back to what Phil and Caroline were saying earlier, I think all of these are really good ways to deal with any patient, right? So in a way, it's like, what are our homeless patients teaching us? Because they're really good teachers, and they're making you really develop your skills and your systems to a better form of healthcare.
Going back to our discussion about determinants of ill health, always challenge the lazy assumption that homelessness is a lifestyle choice. That's just an excuse to do nothing. But you will often hear it on inpatient wards when somebody's about to be discharged, and they say, "Oh, don't worry, it's a life. You know, they've chosen to live like this." That's all. Don't hit your colleagues, but it's well worth challenging. I think I've met one person in 35 years for whom I could say, yes, for that man, homelessness was a lifestyle choice, but it's a silly, lazy excuse.
Phil, can I ask your views on the term personality disorder? Because the only one that gets my blood pressure up as much as lifestyle choice is personality disorder.
There's something real there, but it's very vexed. And the problem is, it's rather like the word schizophrenia. Schizophrenia is used to denote that somebody's crazy man. And personality disorder is used to think, oh, you can't do anything, they're just a bit odd or unpleasant, whatever. There's something real there, but we just haven't got a very good way of talking about it. I would tend to use the phrase personality problems when we had somebody who didn't have a psychosis, who didn't have an affective disorder, who seemed to be behaving in ways that were alarming or difficult or unpleasant for themselves or other people. So I'm going to sit on the fence on this one, I'm afraid. But as we've got onto diagnosis, my top tip is whenever you see the phrase drug-induced psychosis in the notes, the diagnosis is schizophrenia until proved otherwise. If you do long-term follow-up, at least 50% of people with drug-induced psychosis will turn out to have a long-term psychosis after 5 years. So they need following up, they need looking after, they need some care taken of them. So that's another lazy way for people to abdicate responsibility.
And another top tip, I think, is consider literacy and language and ensuring that you are inclusive. Don't assume somebody is able to read and write fluently. We see a lot of people excluded from services and then becoming very embarrassed, handed forms to fill in. So always ensure that you're working with people in a very sensitive way and you're recognizing literacy, learning difficulties, cognitive impairment, again, can be incredibly common from acquired brain injury is again frequently occurring. So have the radar out, if something, radar out for all of those things. And I think really also just to sort of, from what Cleena said, see beyond the behavior and really recognize that sometimes when you see somebody who may appear to have challenging behavior, it can be, it can absolutely be as a result of many different things such as fear, and that when people have been traumatized throughout their early lives, they can be very hypervigilant. They can be on the lookout for expecting to be treated badly. So it's a matter of really focusing, taking the person, seeing where they are and trying to ensure that they feel listened to, they really feel heard, given time. And that can in itself usually de-escalate a problem before it escalates. So I think it's really, really important to think about how you prevent conflict, because then, I frequently see the tragedy of people being evicted from hospital wards because they get uptight. But I've also seen healthcare staff winding people up physically, literally winding them up to the extent you can see they are creating a problem by really not recognizing that somebody is scared, they're frustrated, they don't feel they're being listened to, and that is often a result in them then their behavior then becoming difficult to manage.
Absolutely, Caroline. I couldn't agree more. And I think, when I'm teaching this to medical students or, talking to people, being sick in a bed in hospital, which is where I work, is you're in a very kind of almost childlike state, right? So when, the 5 of us were sick as kids, I presume, I'm assuming, given where we all are in our lives, that, we got to lie in bed and possibly watch some daytime television and get brought glasses of flat 7-Up is the Irish cure for everything. It depends where you were, but that's our experience of being in a situation in which we were sick and powerless. That is how we were treated. And when you're working with somebody who's socially excluded, their experience of life is very much one in which they don't have control. They're being told what to do, whether it's in prison or whatever type of school they are. They're being shamed, given out to, and constantly shamed. And so that's what they're expecting in that interaction. They're not expecting, mother to come up and smooth your brow and give you a glass of something nice to drink. They're expecting healthcare interactions. They're going into that. Their interactions with the world are not necessarily nurturing, and you need to actively address that. So a simple thing that I would always do, and I'm sure the rest of you do as well, is I don't stand over people in bed. I'll go down on my hunkers or sit on the floor so that I'm not threatening, in my physical posture. And I think that that's really important. And again, coming back to what Phil said about us not being taught that relational work, like we need to do it. It's really important, particularly in this group. If you're not attuned to people and their individual life experiences and how those result in their behaviours, you're going to give them very poor care. And I agree, Caroline, like it's an indication of bad care, I would argue, in a hospital setting that you're excluded for your behaviour. It's an indication that as a hospital, as a healthcare facility, we weren't able to meet your needs. And it's not a choice on the part of the person to walk out. We've left them in some way with no other choice, and that's not acceptable. Because that's not fair. It doesn't, you know, how likely are the 5 of us to get excluded from hospital? Pretty unlikely. How likely are the people that we work with to be excluded? It happens very often. So yeah, I think there's a lot of work to do there in how we interact with people.
Thank you, everyone. I'm going to end HLA live panel discussion there for the evening. This has been, I'm sure everyone can agree, such an insightful talk on homelessness and inclusion health. And we heard Cleena describe homelessness as a symptom of social exclusion. We should really be thinking about the advocacy and the difficulties people who are experiencing homelessness have been through, and also thinking about trauma and trauma-informed care affecting the way individuals interact with services. And by understanding these concepts and asking people directly affected, we can meet the needs of those with the greatest needs. So I'd like to finish by thanking our 4 panelists for joining us this evening for the discussion on homelessness and health. And it's a good night from me and a good night from our panel.
Thank you to everyone that made tonight's episode possible. Whenever our scholars are thinking about complex problems facing our health systems, we encourage them to think about how they make significant change in the world of healthcare. We are incredibly lucky to have some incredible scholars in the HLA. They use the HLA as a platform to take their ideas and bring them to fruition. If you are interested in the work of the HLA, why not join us at one of our future HLA events? Why not join one of our programs? Why not even become a HLA scholar? Thank you for joining us. My name is Johan Marlwana, the director of the HLA, and it's a good night from all of us.